Well, Peter, thank you so much for putting this together. I really appreciate it. I'm going to talk a little about AI tools in clinical practice, my disclosures. Quick trip down memory lane. Not that long ago, really in the time of practice of all of the moderators here, we were assessing spinal alignment with poor quality radiographs and literally using, scissors and tape to try to realign the spine. We were trying to guess where the vertebral bodies were. We really didn't have much data on what optimal alignment was. And within the span of about 10 years, we now have automated measurements. We have 3D analysis and AI machine learning algorithms, including not only automated measurement, but assessment of where the spine should be in anticipation of where it will be postoperatively. And now this is a recent case of mine. You see that we've got tremendous number of angular measurements. We've got planning. We've got AI assessment of relaxation mechanisms and compensatory mechanisms within the spine. And it's really come a long ways. And it's happened very quickly. This was 2021. This was my first paper on AI, and I thought it was amazingly ingenuitive. And if you think only 5 years later, there's now literally thousands of papers on AI and spine. And what we did back in, we started this in 2020 and published in 2021. We looked at 915 patients that had full radiographic data. And what we did was we uploaded the radiographs into an advanced AI system, advanced at the time. This was a Brown University supercomputer they have. And we asked it to make self-organizing maps to try to organize the patients into groups that correlated with their clinical outcomes. And we asked it to create deformity morphotypes and clusters. We found that we could create clusters that were associated with rates of proximal junctional kyphosis. And we found that the relationship between the SVA and PJK differed between the clusters. And this is fairly high level, but my idea at the time was the Schwab classification basically was created by alignment scientists, including Frank Schwab and Virginie Lafage, who looked back at all their patients and they said, what radiographic parameters correlate with outcome? And what I asked the computer, I said, forget about those radiographic parameters. What characteristics do you see on the X-rays that correlate with outcomes? And I think that the foray, which was interesting, but didn't create clinically useful algorithms, but was a proof of principle. So what are we doing now in modern practice? I'm going to change gears a little bit and talk about some different ways that we can use AI to actually modify real practice. And I'm going to show a couple examples of friends and colleagues of mine of what they're doing. I have no conflict of interest directly with this. This is something that my partner, Dr. Debo, has been working on, looking at something called Op Agent. And it's an operational AI for orthopedic surgery and pain management. And the idea being that, at least in the United States, the way that we're paid, the way that surgery and clinical care is reimbursed, the way that our practices run is extremely complicated. And this is not completely the United States. And the idea is that we can now use AI to look at our clinical documentation and collections for the way we document and manage our patients. There's a tremendous amount of data coming in every day, and we've found the explosive rise in medical records. AI is now used to document the care of those visits, but we really need more. We need to use AI to understand what needs to be documented, how it needs to be documented, close the loop across one platform. And the idea is that these AI tools can not only help you document what you see on the radiographs, but can then document every administrative necessity you need to get the surgery booked, approved for, and documented appropriately from a medical legal standpoint, and in a much faster way. That's the idea, is that the documentation burden upon all physicians across the world has gone up as medical practice has become more complex, and these AI tools can help make that more seamless. The idea being that also in terms of the way we bill and code these procedures, the way that we make sure that things are all compliant also can be done with AI generated tools. So I think the idea is that many physicians out there are using AI now to document, to code, but this is one tool that tries to wrap all of them into one agent to help make a seamless transition. Now, so that's just the kind of the simple documentation. What about actual clinical care? Yet again, I do not have a conflict with this company, but this is a good friend of mine, Roger Asseker, who's very thoughtful, visionary. His brother's a spine surgeon, and he wants to come up with digital twins to help us create models that can make decisions for our patients. The idea being that we have a lot of data in terms of and spine is right for this because we generally will have x-rays, CTs, MRIs. You get a lot of information about not only the alignment, but soft tissue, envelope, and quality. And we also collect a lot of outcome information. If we can put all of that into AI and create digital twins, we may be able to determine optimal treatment and determine potential outcome. Some of the science of this comes from aviation, where they have spent tremendous resources trying to model aviation performance outcomes and safety. And we have not done as good of a job of that in orthopedics, spine, or neurosurgery. So with Spine Sim, the idea of his group is to use AI and get the maximal amount of data possible into these algorithms so that we can optimally treat the patients. So I'm going to show you some further pictures about his digital twin work. The idea being the more data you have, the better. If we look at things like alignment, I showed you a case of mine earlier. And if you plan alignment based on x-rays only, you're missing a lot about bone quality, about fatty infiltration of muscle, about amount of muscle, about the soft tissue envelope of how obese the patient is. And the idea being the more data, the better. So you can then, as this tool develops over time, you can put all of your data in and you can start checking how the patients will react to certain stimuli, such as standing, flexion, extension, bending x-rays. And then eventually, once we do surgery, you can predict how they'll do and track that over time. You can see, for example, this patient on CT scan has relatively poor bone quality, but also vacuum disc phenomenon that can all be input into the AI tool that generally is not currently utilized in other planning tools that purely based on spinal alignment. You can also assess where their pain is. That's one of the big things that's missing too. Patient spine surgeons love to show imaging, but often we're not honing in. Where is the pain? Is this a lumbar pain issue? Is this a postural issue? Is this a neurogenic claudication? Is it monoradiculopathy? Is it a polyradiculopathy? Carefully assessing and understanding our spinal pelvic parameters and lower extremity parameters is also important, as we've learned over time, and looking at density of tissue, especially bone. And then you can see you can start superpositioning things like spinal flexibility on of what it looks like when the patient's laying down in CT scan, how flexible are they, and then digging deeper into the alignment. And eventually surgical planning, where we can then start planning where the screws go, how the fixation is going to be, and what the balance will be after we fix the patient. Now, what happens after we fix them to the strain on the rods? Yet again, using AI to understand where the rod strain will be may help us to figure out where we need to supplement constructs, such as this patient that's no interbody fixation and no outrigger rod construct. More recently in spine, we start placing interbodies at many levels and outrigger rods at all the levels. Long term, I'd say that's overkill. We probably need to identify where the spine requires these interventions for long-term stability. And AI tools will be able to do that in the future and are getting closer every day. Looking at strains on the rods, rod stress, and we can start even eventually optimizing rod materials. How about adjacent segment disease? Similarly, much more commonly than these big long segment spinal fusions I just showed, we're actually doing short segment fusions. And that places additional strain and stress on the adjacent levels, potentially, depending on the alignment, depending on how stiff the construct is, depending on surgical strategy. And the idea being that ideally over time we can model. We've had things like finite element analysis for a long time, but we didn't have enough data to use it for a singular patient. That was more of a research tool. So as we get more data on the patient's individual alignment parameters, individual soft tissue parameters, we can understand what different surgical strategies will do to the adjacent levels. And I'd say these tools are very exciting. not fully ready for prime time in the office yet, but getting closer every day and seeing how fast these tools are moving. I'd say within a matter of years, these will be widespread utilization in spine practice. But I'll just mention those will then need to be studied to show we're actually improving spine care, and that will take further time because in spine, just because you decrease the adjacent segment rates at 3 months or 6 months, to me is not going to be sufficient to show true long-term value. And so we will need 2 to 5 to 10 year follow-up to really show that we're making a difference. Another one, yet again, I don't have a conflict here, but Vincent Chalier is a good friend of mine, and I think is a visionary in terms of what we can do with AI to understand data. Because I think Dr. Bagley did a great job of showing us about AI and research. And research is closely intertwined with clinical practice. Because if there is valuable data that comes out of research that shows one intervention is better, any thoughtful, reasonable spine surgeon will take that information, and as it becomes validated, will then alter their practice to try to optimize the care of their patients. So in the clinic, we also can use data to improve care and our strategies. So this was a quote from Nature Medicine. It said, there's evidence that AI tools create value for patients, providers, and health systems, and it remains scarce. And the published studies often emphasize technical validity over clinical usefulness. The idea being a call for action that we may be able to use AI and use data to help improve care beyond just what we see on PubMed. And the thing is, if we just use AI to look at PubMed, we'll pull all these different data, apples, oranges, and bananas worth of data. It's actually very hard to put it together. And this was what Dr. Bagley mentioned previously, is that not only is there AI research that literally AI has written a research paper, there's AI assisted research, but even AI's ability to synthesize research continues to be somewhat limited. And so Vincent's take is that maybe able to do better actually using AI, if it's well trained, to not only look at the current literature, but look at very, very large data sets to better synthesize the information we have. And you can use one query and get two very different answers. About MIS TLIF, for example, where a generalist AI may say that MIS TLIF is associated with lower rates of adjacent segment disease. Well, that's maybe technically correct, but the reality is if you can train models such as his that he's named Ask Vincent to look at this, you can find that there's really confounding that says that open TLIF is more commonly a multi-level procedure. And the adjacent level disease may just be lower on MIS TLIF simply because there's more one-level procedures being done. So we need to dig deeper, and we need to look where we're heading of having some true live infrastructure that's being built specifically for spine. The idea being that ChatGPT, Claude are really not good for true spine surgery research, but if you can build tools that are developed just to look at spine data, if you can put a tremendous amount of clinical spine data in addition to what's been published previously, we may be able to really start moving the needle forward on our knowledge of what's being done. What I want to wrap up here with is a nice follow-up to Dr. Bagley's presentation and a recent research publication we have looking at AI and orthopedic and spine research. And we tried to determine using some fairly advanced tools of what percentage of research is currently AI assisted, at least in terms of the writing. This was published in Journal of Bone and Joint Surgery. And we basically looked at all the papers before AI widespread and then looked more recently to detect how many of them had AI assistance. We found that orthopedic wide 16% had AI assistance in their writing overall, which is 1 in 6. These were in different journals, but you see in spine, for example, 14.2% had AI assistance, but in GBJS, 38% had some AI assistance in terms of writing. We followed this up in a paper that's coming out in print, I believe, this month, but was published online in the Journal of Neurosurgery Spine, and created some new thresholds where we basically looked just at spine papers and found yet again that JNS Spine had the highest rates. 31% of papers had people utilizing AI to help with writing. I agree with Dr. Bagley that I think disclosing this is important. There are certain things such as, for example, international authors who are translating to English. It may be very helpful to have AI do this with editing and translating. What becomes much more dangerous, of course, is the hallucinations for the references, the interpretation of the data or a true data assessment needs to be extremely carefully monitored by human intervention. So with that, I want to say thank you again and really appreciate the opportunity to present on this topic.
Thank you, Dr. Daniels. That was phenomenal. Just a quick question. You mentioned some of the surgical t planning tools for your complex deformity cases that you showed. A lot of these are based on algorithms of compensatory changes, injunctional changes subjacent to the constructs, and then it derives the surgical plan reflectively as a result of that. How often are you um, basically trusting the AI? Do you have your own surgical goals, or do you marry the two?
Yeah, that's a great question, Peter. You'll notice I didn't have a lot of slides on this, and here's why. The tools that are currently used are really not truly AI. The way I think of AI, a lot of the large language models taking tremendous amount of all the data that's out there and creating a model where the computer can essentially make predictions about what could happen based on the information it has. Most of the surgical planning tools that are advertised AI are really not AI. They are relatively simple algorithms that were created and patented from modestly large data sets that generally did not include things like the frailty of the patient, the flexibility of the spine, the fatty infiltration of the muscle. So, in my mind, these are actually not advanced planning tools. These are really simple planning tools. And I do use them, but carefully integrated with my own clinical judgment. And you asked me how often I trust them. I often do not trust them in terms of compensatory mechanism alteration because it really hasn't been clear that they're much better yet than a relatively, I'll say, experienced spine surgeon. And someday when we find that the AI tools are clearly superior to an experienced spine surgeon, I'll trust them. I do not believe we're there yet.